Okay, so here is part 3 of the ECG Unit 7 ECG interpretation lecture. And so we're going to continue into some more ECG interpretation, and some of these can be a little tricky and then others a little easy, or rather easy. So hopefully as we close this lecture, you're feeling maybe not super confident at this point, but at least understanding of the material and confident that if you go back and practice, you should be able to catch most of these ECG rhythms. So we're going to get into talking about the blocks. There are 4 types, and the first one is a first-degree AV block, AV meaning atrioventricular. So the blocks identify a conduction problem between the SA node and the ventricles. So if you think about a first-degree AV, first-degree atrioventricular block, the blockage is happening between the atria and the ventricles. So there's something going on, something's delaying or interrupting or messing with the message, the impulse between the atria and the ventricles. So if we look at the first one again, so first degree AV block, if we look at the actual rhythm, it can either be slow, normal, or fast. Okay, so again, a reminder, go through each of your steps. If we look at the P waves, so do we have a P wave in front of every single QRS complex? Yes, we do. Is the P wave normal looking? So is it upright and does it precede the QRS complex? And yes, in fact, it does. What is the PR interval? Is it normal? Is it less than 0.2 seconds? No. So in this case, in the case of a first-degree AV block, here's the problem. The PR interval is longer than 0.2 seconds, or it's bigger than one big box. So if you think back to the diagram of the electricity flowing through the heart, if there's something wrong with the impulse going from the atria to the ventricles, it would make sense that there's a delay between the atria contracting and the ventricles contracting. So think in terms of the conductivity of the heart, the electrical impulse moving through the heart, as well as the actual contraction of either the atria or the ventricles. So again, if there's a problem, a disconnect, a delay, some sort of blockage between the atria and the ventricles, it would make sense that this would be longer. Okay, remember the P wave is the atria contracting and the QRS complex are the ventricles contracting. So if there's a delay, it makes sense that the PR interval would be longer. Okay, so that's a first-degree AV block. If we get into a second-degree AV block, there are 2 types. There's type 1 and type 2. So type 1, you might also hear referred to as Wenckebach. So the second-degree type 1 AV block, you'll notice that the PR interval increases in length until a P wave is dropped. So again, go through each step. I can't emphasize this enough. Go through all of your steps. Here I'm just going to identify what the differences are, but make sure when you're practicing this you go through every single one of your steps. So have a look at the P waves here. If we look at the P wave on this very first complex and look at the PR interval, it's normal. It is less than 0.2 seconds. It's less than one big box. Now if we look at the next complex, that PR interval is greater than 0.2 seconds. And now let's look at the next complex, and that interval is even greater than it was in the complex beforehand. So look at the PR interval. They're getting longer and longer until a QRS complex is dropped. So there's a P wave here, but it's not followed by a QRS complex. So there's some sort of impaired or blocked conduction between the SA node and the ventricles here. So again, the PR interval gets longer and longer until a QRS complex disappears. So it does not follow that P wave. And then you'll notice it starts short again, and then longer, and then longer. And then if this strip were to continue here, you would notice that the next one would be dropped. Okay, so that's a second degree type 1 AV block. Now there's a second degree type 2 AV block, and again this is associated with impaired or blocked conduction from the SA node to the ventricles. So here's where you have a P wave associated with a QRS complex. So we're looking at the very first complex here. We have a P wave. It's kind of difficult to see on this strip, but it is there. So that's your P wave. And a QRS complex. And as you continue down the strip, oh, we have a P wave, but no QRS complex. Move down, P wave, QRS complex. Move down, P wave, no QRS complex. So the P waves are not always associated with QRS complexes, but the rhythm as a whole is regular. So again, the distance between these QRS complexes, this is regular. So it's not one abnormal beat. The underlying rhythm is regular, and there are regular P waves, but they're not always associated with a QRS complex. When the P wave is associated with a QRS complex, the PR interval is normal. Okay, so when the P wave is associated with a QRS complex, the PR interval is less than 0.2 seconds or less than one big box. So have a look at these P waves that are associated with QRS complexes. They're all less than 0.2 seconds. Okay, these P waves that are not followed by QRS complexes, we can't measure that. Okay, and the fourth type, or the last AV block, is called a third degree AV block. And this is where the P waves are completely dissociated from the QRS complexes. Okay, the rate is generally slow, and you'll notice that your QRS complexes are usually wide. So let's track our P waves. So our P waves are regular. So the P waves are happening at regular intervals here, but they're completely dissociated from your QRS complexes. It's almost like you have two ECG strips sitting on top of each other, one of them measuring your atria contracting, and the other one measuring your ventricles contracting. Okay, so in this case, in the case of a third degree AV block, this is a complete block. So the atria are contracting at a rate of 60 to 100 like they normally do. And then the ventricles are contracting very slowly. So the atria are not causing the ventricles to contract in a third degree block. The atria are contracting based on their pacemaker cells, and the ventricles are contracting based on their own pacemaker cells. So these are completely separate systems, but they're happening at the same time. And that's why you can track your P waves regularly. There's one hidden in here, and you can barely tell. It's right there. There's another P wave. So the P waves are tracking very regularly at a rate of between 60 and 100. And then your QRS complexes are tracking regularly as well, probably at a rate between 40 and 60. Potentially even slower than that. Okay, so your third degree block, your P waves are completely dissociated from your QRS complexes. Your P waves are not causing QRS complexes, even though it looks like that's the case here. Keep in mind when your QRS complex is wide, it means that that impulse is not generated above the ventricles. So this impulse is being generated in the ventricles because it's wide. Okay, QRS complexes that originate above the ventricles, so your supraventricular stuff, your tachycardias, your normal sinus, your junctional rhythms, those are all narrow. Those are coming from above the ventricles. In this case, your QRS complex is wide because it's originating near the ventricles. Okay, so these are completely dissociated. They're not causing each other. They're not even related. All right, the next rhythm we're going to talk about is atrial fibrillation. So atrial fibrillation is a very, very common abnormal heart rhythm. You'll see this a lot in the elderly, maybe not so elderly population. It's sort of disorganized rhythm within the atria. So the atria are contracting, but not regularly. So remember we talked about the regularity of automaticity? In this case, the heart is not beating very regular. The atria are fluttering. Sorry, not fluttering, fibrillating. So they're fibrillating, and every so often, one of those fibrillations are going to cause the ventricles to contract. So the atria are contracting irregularly, and every so often, one of those contractions is going to cause the ventricles to contract. So that's why you'll see a narrow QRS complex, but you'll see multiple sort of P waves. This is the disorganized contraction of the atria. It's all of these little P waves here. Okay? Sort of bumpy, looks a little like artifact, not very well organized. The key to note about atrial fibrillation is that the rhythm is irregularly irregular. Okay, so the distance between the QRS complexes is all over the place. You're not going to find regularity here. The distance between these QRS complexes, again, is irregular. It's irregularly irregular. You're not going to find a rhythm here at all. The problem with atrial fibrillation is that blood isn't always pumped completely out of the atria. So there's a chance that there can be some stagnant blood sitting in the atria, and when that stagnant blood is eventually pumped out, it started to clot a little bit. So when that blood has started to clot, it becomes a risk for an embolism somewhere else in the body, potentially even the heart. So the heart, the lungs, in any vein of the body, the brain. So if that blood becomes stagnant, which can be the case in AFib, atrial fibrillation, that stagnant blood starts to clot, and again, that moves around and can potentially cause an embolism somewhere else in the body. The next rhythm we'll talk about is atrial flutter. So in this case, the atria are contracting too quickly, and the ventricles can't react to every single contraction of the atria. So what you'll have is multiple atrial contractions that are regular for every ventricular contraction. So you'll see this sort of sawtooth reaction here. And it's regular. So remember, atrial fibrillation was irregular. Atrial flutter is regular. So again, these are all P waves. So the atria are contracting here. The ventricles, they don't have time to react to every single one of these P waves. So they will react to, in this case, every fourth P wave. Okay, you'll see this regular sawtooth look. And it can be 2 P waves for every QRS complex, or it could be 3 or 4. Okay, usually very discernible. So now we'll get into our life-threatening arrhythmias, and these ones are fairly easy to identify. We're going to talk about our idioventricular rhythm, our VTAC, which we talked about a little bit already, our torsade de pointe, which is a form of VTAC, our ventricular fibrillation, our PEA, and asystole. PEA stands for pulseless electrical activity. So our first rhythm is our idioventricular rhythm, and this is that plan C that we talked about earlier. So this is the pacemaker cells that are found deep within the Purkinje fibers. This is our plan C. This is the heart's last-ditch effort to try and sustain life for a little bit longer. So the rate here is usually about 20 to 40, that should say. There are no P waves because these beats are originating in the ventricles. So again, when an electrical impulse originates in the ventricles, it is wide. The QRS complex is wide. So there's no P waves, there's no PR interval, the QRS complex is wide because that electrical impulse is originating in the ventricles. You might feel this is a little repetitive. I've probably said that 100 times, but it's very important. I'm hoping that you've understood that right now and you're getting a little irritated because I'm saying it 100 more times. When the impulse is generated in the ventricles, the QRS complex is wide. When the impulse is generated above the ventricles, the QRS complex is narrow. And again, the determining factor of a narrow versus wide QRS complex is that 3 little box measurement, so 0.12 seconds. So if the QRS complex is greater than 0.12 seconds, you have a wide QRS complex, which is then originating in the ventricles. So in this case, our idioventricular rhythm, our rate is slow. It's very, very slow. There are no P waves. You can't measure a PR interval. Our QRS complex is wide, and our rhythm is regular. Okay, this patient who has an idioventricular rhythm is very, very close to dying. Okay, this is a last-ditch effort. Ventricular tachycardia, we've talked about already a little bit. It's at least 4 of those PVC-looking beats. Okay, ventricular tachycardia as a whole, so you're seeing it on the entire strip here, is fast. So the beats are usually at least 100 per minute. It's regular. Okay, so you'll see the distance between each of these complexes is the same, so it's a regular rhythm. And they don't always look like this. They don't always look like peak tops. Okay, they can be rounded like this too. So very, very fast, greater than 100 beats per minute. It's regular. And these patients can either be pulseless or have a pulse. If they have a pulse, they will probably lose it soon. Okay, and so VTAC is 3 or 4 or more beats that look like this, so those PVCs. Torsade de pointe, which is a form of VTAC, the intensity of the VTAC will wane. So it sort of waxes and wanes. You'll see kind of like a twisting of the VTAC. So if you were to take a long strip of VTAC and twist it, you would see wide portions and really narrow portions, and wide portions and really narrow portions. This again is VTAC, another very dangerous, life-threatening rhythm. Again, if this isn't shocked or converted to a perfusing rhythm, the patient will die. So these are not perfusing rhythms. The patient could have a pulse with this, but again, will not have one for very long. Ventricular fibrillation, again, is a lethal arrhythmia, so these patients will not have pulses. The heart in this case is fibrillating. It's sort of spazzing. There's no regularity to it. The contractions or the spasms are not strong enough to move any blood to the entire body. So there's no perfusion. There's no strength to the contractions in the heart in ventricular fibrillation. The complexes are fast and they're irregular. So you wouldn't be able to measure any regularity from the peak of any of these complexes. Okay, it's very, very erratic, very irregular, and very fast. And so there are 2 types. There's coarse VFib, where you can really discern these bumps in each of the complexes. It's very obvious. The fine ventricular fibrillation can be mistaken for asystole in a lot of cases. So the complexes in fine VFib are somewhat more difficult to discern. So overall, this could look like a flat line. However, there is enough variation here that if this rhythm were shocked, there's a chance that it could convert to a regular rhythm. And again, these patients do not have pulses. And so PEA is pulseless electrical activity. And this is any rhythm other than VTAC, VFib, or asystole in a patient that does not have a pulse. So it could look like normal sinus rhythm, it could look like a junctional rhythm, it could look like atrial fibrillation, atrial flutter, it could look like anything other than VTAC, VFib, or asystole, and again, the patient does not have a pulse. So there's some sort of electrical activity going on in the heart, but there's no mechanical output. So the electrical activity, again, is some sort of firing of cardiac cells and an electrical impulse moving throughout the heart. But the movement of that, or the electrical impulse, is not enough to cause the heart to beat strongly enough that you can feel mechanical output via a pulse check. Okay, so again, any rhythm that does not have mechanical output, that is not shockable. So your V-tach and your V-fib, those are shockable rhythms. Those are rhythms that you will shock in an attempt to restart the heart into a perfusing rhythm. So again, a PEA is any rhythm other than V-tach, V-fib, or asystole that there is no mechanical output, so you cannot feel a pulse. There are certain causes of PEA. Is your 5 H's and your 4 T's. So your hypovolemia, which is your blood loss or low blood volume, low blood pressure. Hypoxia, so this is your lack of oxygen. Hydrogen ion, so acidosis, so your body, your body becomes in a metabolic acidosis state. Hyper or hypokalemia, so if your electrical ions are out of balance. Hypothermia, so that's the T's are tablets, so an overdose. Tamponade, which is cardiac tamponade, which we've talked about in our cardiac lecture. Tension pneumothorax, which we've also talked about in our respiratory lecture. And thrombosis, which again is a clot, so either coronary or pulmonary, so a clot either in the lungs or in the heart. And finally, our last ECG rhythm is asystole, and this is the absence of cardiac activity. So you'll hear in the movies people talk about a flat line. So asystole is a flat line. It's a straight line on the ECG. There's nothing to measure, nothing to count. There is no electrical activity going on in the heart. And I can't reiterate this enough. ECGs are difficult to get. You will get it by the end of the course, provided you practice. It's something that medics on the road, some are not very strong at, and it's quite common. It's a difficult skill. You need to practice it a lot. I would highly recommend you guys get together as groups, test each other, quiz each other, use the resources that I've posted, use the Kahoot quiz, use the 10 strips I've posted on D2L, and practice. Practice. All right, I think that's the end of part 3. So you should have 3 parts for this lecture. Take your time, go through it slowly, make sure you understand it step by step. And we do have 1 open lecture, so bring your questions then and we can practice.